Good afternoon and a very warm welcome to you all to this Provincial Parliament Ad Hoc Committee on COVID-19. It is Wednesday, the 31st of March 2021. My name is Mireille Wenger and I'm the chairperson of this ad hoc committee. I would like to extend a very warm welcome to the Provincial Department of Health, to the Minister of Health, Dr. Namafrench-Mbombo, and the Head of Department of Health, Dr. Keith Cloete. I'd like to extend a warm welcome to the members as well and the representatives of the Health Department that are joining us presently. I'm going to table apologies at this point. I have received an apology from Honourable Heron from the Good Party, and I've been notified that Honourable Bosman from the DA will need to leave the meeting at 4 p.m. Are there any further apologies to be tabled at this stage?
Chair, Member Christians, I need to leave the meeting at 3:30. Thank you.
Thank you, Honourable Christians. We will make a note of that.
Chairperson, sorry, there has been another apology. Mr. Ibrahim, I think he said, for today, ANC, Mohammed, I forgot the name now.
Honourable Syed.
Yes.
Thank you, Ms. Jones. We also have received an apology from Honourable Syed. With the apologies out the way, then I'm just going to quickly deal with the rules of engagement for virtual meetings, which we're all very familiar with, but just for the record, all members and participants are muted at the beginning of the meeting to avoid background noises. Members should please flag any points of order by using the raise hand function or by using the chat box. We ask that all video and audio be switched off during the meeting to improve the quality of the connection. However, if a member, minister, official is speaking, we please ask that they, of course, use their mic, and they're welcome to use their video. We just ask that the video be turned off once the inputs have concluded. We ask presenters to unshare their presentations once the briefing has concluded. And finally, the rules of order for this meeting come from the directives for sittings of the House and meetings of committees by electronic means, which were ATC'd on Friday, the 17th of April 2020. So, members, today's meeting will be split into two parts. The first will be a briefing by the Provincial Health Department on the COVID-19 pandemic and its indicators, as well as health indicators and, of course, the vaccine rollout in the Western Cape. We will then have our Q&A with the department. Thereafter, we will have a briefing from the South African Health Products Regulatory Authority, SAHPRA. SAHPRA will join our meeting at 3:45. We will then have a Q&A following that engagement. And just by way of some introductory remarks, the pandemic is fast moving and changing, and similarly, the needs of people move and change. And so it's important that we as Parliament move with these changes and can understand in the best interests of the people that we represent how the pandemic is being managed at the various levels of government. And so on that note, I'd like to see if the Minister of Health, Dr. Namafrench-Mbombo, would like to make some introductory remarks. Sorry, Minister, before, sorry to interrupt you, I see we have a point of order from Honourable Doug Moore.
Thank you very much, Chairperson. Chairperson, I just wanted to ask if you wouldn't mind giving a time frame for how we're going to conduct this afternoon. I think you're aware that previously members have raised concerns at the length of presentations. I've just had a quick look at the Health Department presentations, and obviously it seems to be about 60 slides. So if you could just indicate how much for the presentation, how much for questions, and the same for the second input that will be done by SAHPRA. Thank you.
So we've been managing this quite successfully over the last few meetings. The Health Department's presentation will be 45 minutes. And as mentioned at the start of the meeting, SAHPRA will only be able to join us at 3:45. So we will have the Health Department with us until that time, unless we conclude a little earlier, in which case we will deal with some committee admin while we wait for SAHPRA to join the line. Thank you very much, Minister. Over to you.
Thank you.
Minister, we seem to have lost you. Are you still on the line?
I press.
There we go.
Yeah. Thank you for this opportunity for presenting at the ad hoc committee, which is the last day of the officially budget financial year for 2020. Tomorrow is 2021. The items on the agenda that we were asked to reflect on is on situational analysis and the health update, the seroprevalence study, the projections on the third wave, and also for the rollout of the vaccine, which the team will be doing the presentation. Just a quick 1-minute summary. We need to reflect that the virus has always been, ever since we had our patient zero, it mirrors it differently country to country and also province to province. And also within the province, we'll find that district to district. And within that district, we'll find that sub-district to sub-district might not be the same. Just making an example, when Dr. Krut is going to present now, you will see how there's a comparison of where the pandemic is, first, second, third wave in South Africa context, and also in other parts of the world, like in Europe and South America. Similar, when we did the presentation before, specifically on the second wave, we did reflect that Khayelitsha was hit hardest by the second wave compared to the other areas. Similarly, where in the second wave, what we could call it epicenter for second wave, according to the data, you'll find that it started where in the Eastern Cape. Similarly, when it comes to the deaths, whilst you'll find that Western Cape might be quite very successful in data collection, and therefore, whether the numbers going up, or for example, for the deaths, but it's a true reflection because you might have fewer excess deaths as compared, for example, the Eastern Cape, the KZN, in Gauteng, where you'll see quite a large number of the deaths generally. Northern Cape, the data that is in front of us in South Africa, you'll find that even in the Northern Cape, while all other 8 provinces actually have plateaued, but you'll find that there are still some Northern Cape where it hasn't actually shown some decrease, but the numbers are very few because the Northern Cape people are very fewer. So where we are now in all the indicators, it does show that we are going down, and taking note that learning from the previous waves, it takes about an average of 2 months to 3 months, where probably we can see something else. But noting now there's a variant 501YV2, and also there are others because of the mutation. So it's not only about where we could be able to, but some people ask us, what happens to the modeling? But with the variance, you'll find that it becomes difficult to do the finalization of the modeling. However, in regard to the deaths, if you compare the deaths, the major contributory causes of those who are high risk, comorbidities, specifically diabetes, and the older persons. It was like that in the first wave, and it has been like that in the second wave. So when you get more numbers, it's about the pool or the denominator. It's not like as if that there might be fewer deaths. The evidence in front of us, it does show that the South African variant, whilst it may be highly transmissible compared to some of the other variants, however, it's not lethal compared to, for example, 50Y1V1, which is for example, the one that is a variant that is found in the UK. But it does mean that for those who are vulnerable, will be quite a high risk. So that's why with the vaccines, we are still not happy. We are still we're not relaxed that the older persons have been vaccinated yet. And then in regard to the sources of getting to know what is the pandemic in terms of where are we and all of those. Whilst we might not be testing much in regard to the PCR testing, which is the individual diagnostic testing, but you need to understand that already we could be able to know what is happening in certain areas without necessarily going and testing almost everyone. For example, like now we're going to present the seroprevalence. Take note that there's also the wastewater in terms of the sewerage, where people can be able to assess and see whether are they strains or not. Similarly, where you may be aware, we did present here the data that came from the blood services, which is for those people who are donating blood in regard to randomly just checking whether there are any antibodies. Similarly, at the beginning of the year, which is I think Dr. Chris is going to present now, where it also the second part where it also involves the children, where randomly you can be able to use blood for like antenatal care. They're coming for antenatal, but they'll be taking blood or for HIV and all of those, where you can determine the sources of if there are any infections or viruses there. In regard to the rollout of the vaccine, again, remember, as we indicated earlier, at this stage, it's the Johnson & Johnson, which is at this stage, which you're going to hear actually, because I saw that SAPRA is coming, which still is being approved by SAPRA as the part of the implementation study to roll out to the healthcare workers. And Pfizer, which has been approved as a Section 21 at this stage, and also some of the other candidates that have submitted to the SAPRA for their approval. I'm not sure whether it's a Sinopharm or Sinovac, but around that part. Therefore, lastly, Speaker, Chief Whip Chair. So lastly, now when it comes to the third wave, that we have got only the healthcare workers, and not only all of them, because for us the target is about 33,000 for the phase 1. That only it's about 40% that could be able to be vaccinated until we get other doses later. That there is no public that has been vaccinated, it means that we are still likely to be exposed to infections, and when and how the third wave will be determined in regard to the community transmission. Hence, we are worried about now this long weekend in regard to the gatherings, people closer, even within not only the gatherings, even at their homes, where they get exposed, where there's no 1.5 meter distance. So that's why we say to the people, keep it safe, keep it short, and keep it outside, and mask up, and try not to, especially if there are gatherings, to sing. So over to Dr. Casey in terms of the presentation, taking note of the time that now needs to be shortened. Thank you.
Thank you, Minister. Very warm welcome, Dr. Klitty. I'll hand straight over to you.
Thank you very much, Chairperson. Can you see the slides?
Yes, we can. Thank you.
Thank you very much, Chairperson. And just to reiterate for the members, you normally get a set of slides from us. And because we update this data every day, 3 hours before the committee, I then send you the latest updated slides. So you will have two versions, the one that was sent to you over the weekend and the one that was updated this morning. But in essence, I will be within a allotted time frame, Chairperson, and it will cover the surveillance and response update, our health platform response, well-being of the healthcare workers, vaccine rollout, and conclusions. So just on the surveillance and update where we find ourselves, we can truly say now and confirm to the committee that we are coming out of the second wave. We are in the intervening period in between waves. If you more or less compare where we are now, following the second wave, we are in a similar position where we were around about October after the first wave. So you'll see oxygen use, hospitalization, deaths, and cases are all in the same vicinity of plateauing and being at the low, but plateauing at the low base. The mortality, the Minister referred to it. This is our mortality figures. We've also now reconciled our daily prospective reporting on deaths with the Home Affairs data that comes out of the MRC excess report. So our deaths is now even closer aligned to the MRC reports as it becomes available to us. The reproduction number, if it goes over 1, that means you're starting to see an increase in cases. And for today, I'm just going to show you it is slightly gone just above 1. And it's mainly because of some increased testing and increased cases that's been detected in the metro in the last 7 days. This is the provincial overview. The new cases are now 5% up from the week before, and it's mainly due to the metro increase. The admissions and deaths, though, continue to decrease, 22% lower, and the deaths 62% lower of the week before. Proportion positive is stable at 5%, which is a sign that we are actually testing sufficient people at this point in time. Everybody that should be tested is being tested because only 5% of all our samples come back positive. We are now seeing the similar numbers, as I said, that we saw in October. If you go to the metro, you see a 16% increase, and this is largely driven by private sector testing in northern, southern, and western. So there's been an increase in private sector testing in those areas. There's no specific clusters, and it's mainly been testing prior to people going for surgery and then also for traveling. And that's why we've got a few higher case numbers in the last 7 days because of that. If you go to rural, it's more or less the same, a 0.3% increase week on week. There's a wide variation across the districts, sometimes up, sometimes down, but we continue to watch for local outbreaks, and as they happen, we contain. And we're very vigilant now for the upcoming holiday period. This is what we do as a standard now. We call it the surveillance huddle. This was the conversation of yesterday. You'll see in Khayelitsha Eastern, no real concerns. Klipfontein, Mrs. Plain, no real concerns. But Northern Tygerberg, those pre-admission tests and pre-travel cases in the private sector. In Southern Western, this is where the tin roof incident happened in October. So the team is very vigilant. They actually picked up that between the ages of, the older age, the 18 to 30 age group, they're watching it carefully. But they picked up some Stellenbosch University cases because somebody's residential address is in Southern Western, but that's obviously linked with the Stellenbosch team. But there's also been shipping companies that's been picking up asymptomatic cases because they've done routine testing on all the people that were on the ships as they come into the dock. In Cape Winelands, there is a concern about Stellenbosch, and I'm talking about those 3 cases that were picked up by address in Southern Western, but they are actually on the residence in Stellenbosch. And they're concerned about the 18 to 30 age group. So really no mask wearing, poor adherence in Stellenbosch as a town. The teams are all very familiar and aware and are engaging the university and the students all the time to try and contain the behavior in Stellenbosch. Central Karoo, Garden Route and Overberg, nothing really to talk about. Overberg, there's a Teslarsdal. It's a very small town outside Caledon. And it's a funeral cluster of 5 cases. And the team is on top of it, picked it up quickly, contained it. And these are the kind of things that the team is doing across the province all the time now. This is the wastewater. And again, in the wastewater, unfortunately, 3 samples couldn't be taken this week because of protest. But in wastewater, generally, there's been a decline, and we have fewer plants showing COVID in the wastewater, which is a good sign. For instance, if you go to Theewaterskloof, it's for the 2nd week in a row that there's no COVID in any one of the 4 treatment plants in Theewaterskloof. And actually in Caledon, there's been no COVID in the treatment plants since the 1st of March. If you then go to the 3rd wave, and we'll come into the conversation that was prompted for us to give feedback today. There's a Ministerial Advisory Committee, and I just want to clarify. The Ministerial Advisory Committee is a national committee. Our Western Cape epidemiologists that did our 1st wave and 2nd wave models serve on that advisory committee. They have now released a Ministerial Advisory, a MAC advisory, and the National Modeling Group will be releasing models for the 3rd wave in the next few weeks. So that work has all been done, and we're not doing independently from national. We're working with the team, and there will be one set of national models for the whole country. But in that team, they're considering the following. Change in season and weather will influence the 3rd wave. Behavior change, very important. If restrictions lift, and especially because we're in level 1, that increases the risk of the 3rd wave. Then interaction between subpopulations, that is movement between provinces, movement between urban and rural, movement between wealthy and poorer suburbs. Those things all adds up to the risk of a 3rd wave. Then the last 3 ones, the second last one is variants. That is, you all know about 501v2, and there's scientists that's checking all the time for potential other variants. And the last one is how quickly can we take up vaccination, because more people are vaccinated that are vulnerable, the smaller the risk for the 3rd wave. And then the 3rd one, the one that's highlighted, is what is the level of immunity post-infection from the 2nd wave. to understand what is the impact likely to be on the third wave. So today we're giving you feedback on that, those results of seroprevalence. So just to contextualize this seroprevalence were taken in the middle 2 weeks of February, and we take blood samples for people that come to services for blood being taken for purposes other than COVID. So this is diabetics coming for their routine care, both in the public and private sector. It's also people with HIV coming for their routine care, where they have to take blood samples and the laboratory has the blood samples. And then also public sector children under the age of 15 that attended the Red Cross and Tygerberg Hospital. 53% of which were outpatients, therefore 47% were actually inpatients. What the laboratories then do is they take all these samples and do an antibody test to look for the evidence of COVID antibodies on those samples. The results of that is the following. So we're going to start with the public sector diabetics, because that is samples that we have for the whole province. And what you see here is you see a variation that in 33% of the samples of people attending for public sector diabetic care, 33% in the West Coast showed signs of COVID. That's in February. That's compared to 20% in October. If you go to the metro, 47% of the samples show evidence of COVID, compared to 28% after the first wave in October. So you can see the highest and the lowest. West Coast is the lowest for 33%, Metro 47%. Everyone else is in between. Overberg is about 46%, and then Cape Winelands and Garden Route is actually close to the Metro. Cape Winelands is about 46%. Eden about Garden Route about 45%, and in Central Karoo about 42%. What does it mean in the metro? Let me show you then. If you then take those 47% in the metro, you compare it with people that in the metro then took blood samples for people with HIV coming for care. 60% of those samples showed evidence of COVID. So it's higher for HIV than it is for diabetes care. If you then take all the children that was taken then at the Red Cross and at Tygerberg, 36% showed evidence of exposure to COVID. If you take all the people that attended for diabetic care in private in the metro, you'll see that it's only 26%. So what this says to us is that the public sector prevalence is highest in people with HIV in the metro, and it ranges across the sub-districts from 54 to 70%. For diabetics, it's 47%, and I'll come to that one because it ranges from 37 to 68. And then in the second wave, more than 20% of all the sub-districts increased from the first to the second wave. And the lower prevalence is children in the public sector, 36, but the lowest generally is private sector diabetics at 26%. So what does it all mean? If you take then the diabetes and you take the sub-districts, and this is where we come to the Khayelitsha situation. In Khayelitsha, the diabetic public sector now exposure to antibodies is as high as 68%. Before the second wave, which is after the end of the first wave, it was 50%. And in a sense, we have evidence to suggest that because it was 50% after the first wave, it gave some kind of immunity and cross protection to the population of Khayelitsha. Therefore, the second wave was lower. You can now see that places like Klipfontein is now above 50%. You can see Eastern and Western is starting to approximate 50%, and Mitchell's Plain, and Tygerberg is a bit lower, and then Southern and Northern is lower. If you compare that to the private sector diabetics in those same areas, you can see in Southern, only 20% of private sector samples were positive. So if you then take the next thing is, if you take all these samples and take it by age group, we show that the highest prevalence for all these groups that I just shared with you now is between the ages of 30 and about 45. When you start going over 45 to about 60 to about 70, it's decreasing. So you also then see that people that's over the age of 50, and generally when you get over the age of 60 or 70, have significantly less antibodies against COVID. So what this all means, 65 to 75% is more or less what we talk about as herd immunity generally. None of the areas that we just showed you have that level. So every area will still have a third wave, but it is likely that in some areas, the third wave might be more expressed than in other areas, and there might be protection in some areas, depending on how high the prevalence was. So this is just to give you a global trend. You can see what the picture is like in Western Pacific, in South Asia, Europe, where they are onto their third wave. You can see Eastern Mediterranean onto a third wave. You can see the Americas onto a third wave. And you can see the African region coming off a second wave. And us in the Western Cape, you can recognize this as the pattern, not only in South Africa, but across the African region. You can also see the variant that was here, 501V2. You can see that it's now been reported in 75 countries and in 11 countries in the last week. You can see 501V1, which was in the UK first, is in 125 countries, 7 in the last week. And just a reminder for all of us, our first wave and second wave actually all started with imported cases that we reported right back in March, April last year, that led to the fact that we now have 278,000 cases. So our vigilance for people with variants moving across the world is something that also should be considered in preparation for the third wave. So what does this all mean from that seroprevalence? We believe that where there's a high seroprevalence, there may be a measure of protection for a significant impact for the third wave, but we should still plan for adequate mitigation. Where there's low seroprevalence, there's potentially a more severe impact for the third wave. And it should be taken into consideration for us in planning to mitigate for these areas, in addition to what we normally would prepare. So overall, we should plan for mitigation in rural districts, especially in West Coast and Overberg, and with the private sector in general, and for the elderly, as you would see. Because the more older you are, the less antibodies. And actually, when they come to the vaccination program, it supports that the vaccination program should start with the oldest people and work down, because the risk is the highest in the older age groups. And then we should plan for access to beds with oxygen supply, and specifically access to high flow nasal oxygen. That should be a key focus for our third wave. As I've just said, we are pulling all our third wave plans together. The national modeling is coming together, and in the next 2 or 3 weeks, we should have our third wave plans all articulated and clear, with clear trigger points of what it is we need to escalate. We've learned a lot from the first and second wave, and we feel that we are in a position to prepare appropriately for the third wave. The recommendations for the holiday period, our first priority now is to delay the third wave. So there's numerous public holidays coming up where people will travel for religious and for family gatherings. These gatherings pose a high risk of being super spreader events, and it could easily lead to the third wave. So we are proposing avoid unnecessarily interprovincial travel, avoid gatherings, especially with a lot of people from different places, and especially when there are older people with comorbidities or people with comorbidities. If people have to gather, it should be small and it should be short, preferably outdoors, and it should be quiet, not a lot of talking, not a lot of loud singing, because we know that spreads the virus easier. And social distance, ventilate, mask up, hand hygiene all the time if people have to travel or gather. And these are the messaging. The messaging campaign is going out, and it's trying to reach everybody over the next 2 or 3 weeks. The health platform, we can currently say, as of yesterday, there's 794 COVID patients in all our acute hospitals, public and private, across the province. That's now only 6% of all the beds is covered with COVID. Hospital of Hope, Brackengate, has only got 19 patients. The Hospital of Hope in Mitchell's Plain has 9 patients. And actually, what we are doing is, because we're systematically closing down the capacity to be able to open it up again if we start triggering into the third wave. And we will keep Brackengate going, but we will close the Mitchell's Plain Hospital of Hope for now until we need to open it up again when the right time is right, and the cases start increasing. The Mass Fatality Center has only got 4 decedents now, and they have to date managed 1,384 bodies in that place. This is the overall dashboard picture. It gets updated 1 o'clock every day. We're keeping it going every day of the year, and this is what we will be keeping an eye on. As of yesterday, 80% of our beds were full. only 6% was due to COVID, and all the COVID beds we had yesterday, only 14% had people in them. If we go to the oxygen, we're down to 23.9 tons of oxygen per day. The public sector is down to 15.4 tons. This compared to what we did at the peak of the second wave, we used 51 tons in the first week of January. And we are now planning for our oxygen deployment in preparation for the third wave. The healthcare workers, as of today, we have 23 healthcare workers that are active. At the peak, we had 1,000 healthcare workers active. And I just want to point the committee to this last figure. You will see March 2021, 37 infections in healthcare workers. If you go back right up until March 2020, 37 healthcare workers is the lowest since March 2020. And every other month in between has been more than 100 healthcare workers infected. I mean, this is a record low, and we're starting, and you can start to see that now. We're ascribing that to the early impact of the vaccination amongst healthcare workers. Already, we're seeing the impact in that regard. And if you look at this picture, this is us tracking week by week cases. And you can see in the last couple of weeks, 5 cases, 1 case, 2, 3 cases, 1 case, 4 cases. That is what we're seeing now as compared to what happened between the waves in September and October. And we're looking forward, obviously, as more healthcare workers get immunized, that the trend will continue in this way. In terms of staff, we've now employed 1,132 staff members. They are being deployed across the immunization service and in preparation for third wave. So then brings me to the vaccine rollout. In terms of the vaccine rollout, the Sisonke program, which is the first one with the J&J, we anticipate that we will be able to cover 50% of all healthcare workers in this province with the limited doses that has been received via the Sisonke program. And we are preparing to scale up vaccination during the month of April to complete phase 1 with an expected arrival of Pfizer vaccines early in April. So this is the update of Sisonke. You can see since the launch on the 17th of February, we have now received our 4th tranche of the initial 300,000 vaccines. And that will take us to the 10th of April. After the 10th of April, we will get additional doses from the additional 200,000 doses of Johnson & Johnson. We are currently projecting that we'll get about 30,000, but we will still see how that unfolds. Each of those vaccine tranches is broken down, 13,000, 13,000, 18,000, 9,700. So in total, we've received 54,000 to date. As of yesterday afternoon, we have immunized 45,900, just short of 46,000 people, healthcare workers across the province, public, private, across all the areas in the province. These are the vaccine sites. In the metro, it's Melomet for the private sector, then Khayelitsha, Grootskeur, Tygerberg, and Mitchells Plain for the public sector. In rural, it is Worcester, George Paul, and Caledon, and they are immunizing private and public as we speak, including community health workers, including all healthcare workers in these geographic areas. The vaccine update, the system that is being used, the electronic vaccine data system is the national system. We've learned a lot. We've also got some provincial level controls now, so we know how to interact with EVDS and make the system and the processes work smoother for us. This is the updates. You can see we've gone from the 17th of February. We're now at the 45,960, and you can see how many has been done. Grootskeur has done the most, 12,500, and Caledon 730, having started only last week. We have trained 2,351 vaccinators out of 444 that's been enrolled, and that's growing all the time. And that brings me then to the phase 2 preparation. And this is to target to start in May. So we've learned a lot from the international experience. We've got international case studies from all the countries that have done well. We've even had last week an engagement with some states, the state of New York, that use Pfizer vaccine via a national meeting, and we could learn from them how they do it in terms of us receiving Pfizer and the temperature control and all of those. But the idea is there's 4 big things: high-level leadership and commitment. There's information systems that make the scheduling of appointments quickly and you can monitor and report. There's effective communication, and you've got citizen engagement and buy-in. And then you've got a highly organized and efficient logistics. Our own local experience with Sisonke taught us about how to set up vaccination sites, the vaccinator training, about information systems, our registration and appointments handling, how people behave, because some people wanted to jump the queues, how vaccine logistics work, how to govern, and how to work with stakeholders. So we've learned all of that. We're putting it all together, and we're doing planning for phase 2. I head up a Western Cape COVID-19 steering committee. Our second meeting will be next Tuesday. I also serve on the National Vaccine Coordinating Committee. And we have a project office, we have an advisory committee, we have a private sector coordinating committee. And then you will see the 3 streams from the international experience, but also experience from the Independent Electoral Commission in this country, the IC, on social mobilization, operational logistics, which is the big drive, and then information systems. This is the national supply line for vaccines. The main supply line is for Johnson & Johnson and for Pfizer vaccines. Those are the 2 that's been registered or are in the process of being registered with SAPRA. And the national government is at advanced stage to confirm the contracts for the arrival and the delivery of those vaccines. This is the predicted supply over the coming months. So what I've got shaded in red, light red, is what is SAPRA approved. So you'll see Pfizer is SAPRA approved. You are about to talk to Pfizer, to SAPRA. You also see that Johnson & Johnson has got approval for the Sisonke trial, but they got a rolling application for the vaccine as it becomes available. You know that Covishield was granted by SAPRA, but the rollout was put on hold. Moderna is the other vaccine, but they have not submitted to SAPRA yet that we know of, and we don't think that they will submit to SAPRA before the 3rd quarter. Then you heard the president last night, maybe, that he was talking about Sputnik, Sinovac, and Sinopharm. Those 3 have all submitted applications to SAPRA. It does not seem that the approvals are imminent, but SAPRA will give update, and we always check in as well with their processes. And then the only other 2 vaccines that has had phase 3 trials completed is Novavax and Bharat Biotech, but they have not submitted anything to SAPRA yet. It might have changed in the last week, but as far as we know, they have not. So we take our guide from these. So just to give you an update of the Western Cape acquisition program then, the process followed by an acquisition team. It's set up by us in Provincial Treasury. These are supply chain experts. They've got a standard process for all people that come and say they have vaccines. 28 agencies, entities have made contact. We've made follow-up with each one of them for specific detail. Each submission is evaluated accordingly with due diligence. And when this is all completed, we'll see whether there's anything that comes out of that. But we have then made proactive approaches to J&J and Pfizer, because you can see from the pipeline, they have registration with SAPRA, and that is the vaccines that we expect to come online. Both have replied that they're currently supplying the National Department at this stage. It doesn't mean that in future they won't supply directly to us. The next steps are, we continue with this, what we call targeted request for information process, with a view to start acquiring some vaccines by August 2021. Specific follow-up with foreign governments is explored by .P, because if any donations will come forward, it will be processed in terms of standard procedure for donations. And we're also engaging with the private sector through existing structures. They're part of the steering committees, and we work together to make sure that we have a combined public and private sector vaccination drive, and not the parties pulling separate from one another. We also document the liability and no-fault provisions, and the team is assessing our options for Western Cape government in this regard. If we should procure vaccines, that this is then legally covered. This is the portfolio. If you look at this slide, it's really how the national program should unfold if the 40 million people in the country should be vaccinated before the end of the year. Now that requires to get up to 250,000 to 300,000 vaccinations per day. That's on the assumption that between the public and the private sector, there will be shared 50-50. In this province, we believe we should then contribute 30 to 36,000. We are currently doing projections to go even above 40,000 vaccinations a day to our contribution to this national target. There will be small sites, medium sites, and large sites, And it's a combination of getting this right to be able to achieve this high level logistics to be able to achieve that level of vaccination per day. We've done our own modeling, obviously, in this province, so we're going to do our 30 to 40,000 a day. If you want to do phase 2 in a space of 3 months, it says how many vaccinators do we require, how many vaccines should be done by each vaccinator for each of the geographic areas. It's the rural districts, and we've divided the metro into 4 substructures. This is a vaccine calculator, so all the local teams are working on this. So we are now providing for an extra large site, which would be about 2,000 vaccinations per day. For extra large sites, we'll do about 750 a day. Large sites, 500 a day. Grootskei and Tygerberg already are doing around about those numbers, 500 a day, and Gatesville as well. Medium size, 300 a day. That's your slightly smaller hospitals. And it could be community health centers. Small sites would be clinics. And then outreach sites, that is when teams go out to places like old age home, frail care, and you would do about 50 a day. So this spectrum is what we are asking people to say. How many days are they going to operate? How many vaccinators do you require? How many vaccinations per vaccinator do you require? How many vaccinators is required per day, per site? And then how many sites? And you calculate it. And this is currently being done for each district in the province. So what the districts are looking at, they're looking at this choice of vaccination model depends on how widely the population is distributed. So in Central Karoo, you're going to have a slightly different mix. And in the metro, you're going to have a different mix, depending on how wide people are, what the priority groups are, and how you want to be efficient in terms of what you do. So the larger sites probably will be about 4 to 8 in the metro, but only probably about 4 in the rural and in the bigger towns. Medium hospitals and CHCs, and then small will be outreach team and maybe private pharmacies, small clinics as well. And there's a database of sites that's currently been prepared in each of the areas, and there's criteria to select the appropriate combination of sites in each area. So more or less it's going to look like this for phase 2 from May. There will be mass vaccination sites at various sizes across private and public with some outreach, and the teams are putting this together for their own local areas. So this version for Overberg or for Agulhas will have a specific version, as opposed to Mitchell's Plain in the metro will have a specific version of this. The national colleagues, we work very closely with our national colleagues. I want to stress that point. Their allocations for phase 2 will be an age-based prioritization. And they, at this point in time, are proposing that probably the general population vaccination and the industry-facilitated vaccination sites should first start with everybody over the age of 60. And then sequentially after that, based on vaccine availability, we work our way into other age bands. So you would go for over 60 and then 50 to 60, then 40 to 50. When you get to under 45, there might be at a later point to say, okay, if you get to under 45, is there a prioritization for high-risk industry and industry workers? That's a conversation we'll go in. We believe this is a much smoother and it's a streamlined process, and it will be easier logistically to manage that across private and public when you do mass vaccination rollout. So Chairperson, in conclusion, our current situation is one that we've navigated and we've exited the second wave with clear and consistent decline in cases, hospitalization, and death. We're now in that in-between phase where we have heightened surveillance, vigilance. We urge everyone to adhere protective behaviors to reduce new cases while we are in level 1, especially this holiday period, so that we avert an early onset of the third wave. We need to push this third wave back as far as we can. We have reflected on our experience of the first and second wave, and we've learned. We know what we need to do in the coming 12 months. We do require a whole of government, a whole of society to mitigate the third wave. But more importantly, while we're doing it, we need to significantly step up the implementation of vaccines over the coming month as the key drive against COVID. Chairperson, thank you very much.
Thank you very much, Dr. Cloete. That was very well timed. Perfectly, exactly 45 minutes. Thank you very much for that detailed presentation and for answering all the questions that we had set out in our letter to you. I'm sure members have questions now, and we'll use the same system that we usually do. So I'm first going to remind members that each party represented on this committee will have a 3-minute opportunity to pose questions. So let's start with the DA. Are there any questions from the DA, please?
Yes, Chairperson.
Thank you, Honourable Philander. Over to you.
Thank you very much, Chairperson, and thank you very much to the Minister as well as Dr. Klutter. Chairperson, my first question will be on the vaccine rollout. Dr. Klutter has made mention of the 132,000 healthcare workers in the Western Cape, as well as vaccines received and those administered at current in the Western Cape, as well as the scaling up during April of this year. Chairperson, the President last night made mention of the inception of phase 2, and which is anticipated to start mid-May. My question would be in terms of the planning and the timeline of province and national. Does the department anticipate an overlapping during this period? We know that there has been a delay in the supply of vaccines. And does the department have the assurance of the timely arrival of vaccines to complete phase 1 in the anticipated period as mentioned, Chairperson? And then my second question, what derived from the presentation as well, what accounts for the changes in the number of vaccines that the provincial government receives from national? One can see the discrepancy. There's a difference in each batch that are received. And also, are the department informed in advance of those changes, and round about when does the department receive that information? My third question, Chairperson, is the department at this stage concerned about the variant that was first detected in the UK? That is now currently in South Africa, and can the department perhaps confirm whether this variant is more deadly than the others? Chairperson, if the time allows, I know Dr. Klutter made mention of pushing back the third wave as far as possible. Projections, can the department at this stage say or anticipate when a third wave, and also considering of the various factors that enhance a third wave? But can the department at this point perhaps give an indication as to when it is expected, as well as with the intensities thereof? I'll conclude with those 4 questions for now. Thank you, Chair.
Thank you, Honourable Philander. You had about 15 seconds. That was well timed. I'm now going to recognise the ANC. I see Honourable Dugmore.
Thank you, Chair. Myself and Honourable Winfogel will be sharing this 3 minutes. But just to say, firstly, thanks again to the MEC and in particular Dr. Klutter for the presentation. A lot of very important information on the progress which is being achieved. The first question I would like to ask, there is mention that the George Hospital is one of the sites where both public and private healthcare professionals and workers will go for vaccination. But in the slide, and possibly that can be put up again when he responds, I didn't see an actual total that had been allocated to the George Hospital. Maybe I didn't quite see that, but if you could just clarify whether that's up and running and how many vaccinations have actually happened out of the George Hospital. And then in the report on the process of the Western Cape trying to procure its own vaccines, there's mention there of unsolicited bid, and also the fact that I think 28 individuals and companies have been contacted. Could you please clarify how many unsolicited bids has the province received, and from whom those unsolicited bids were? And then finally, from the President's announcement, it seems that there is definitely progress being made on the Johnson & Johnson vaccine. And for me, there's an advantage in that it requires one shot, and we've also heard about the local production in PE. So could I just ask, in terms of consideration from the Health Department, how strongly does the issue of a one-shot vaccine as opposed to a two-shot vaccine weigh in determining possible alternatives. Sorry, I went. Chair, thanks.
Thank you. Honourable Windvogel, do you want to take the final minute?
Okay, yes, Chair. Thank you, Chair.
Okay.
Can I proceed, Chairperson?
Yes, please.
Hello. Okay. Yeah, Chair, mine is on the issue of I want to understand how the rollout of vaccine is going to work in the rural areas. Because what I noticed was that we have 3 vaccination sites in the rural areas. Then furthermore, the health workers from Swellendam have to go to Kellington to be vaccinated. I would just want to know, are you also going to decentralize the vaccination as it was done with the testing? Then the last one, Chairperson, on the 1,132 new employments, I want to know, is it permanent staff or temporary staff? Thank you, Chairperson.
Thank you, Honourable Windvogel. I'll now recognise the ACDP.
Thank you, Chairperson. Thank you. Thank you for the Minister and also the HOD for answering our questions. Just a question, Chairperson. I've heard that Dr. Klukter spoke about the holiday period and also people traveling for religious and family gatherings. Just question is, after the churches were open at 100 inside and gatherings outside could, I think, be 250, was there any super spreaders since then? Also, if you look at the compliance side, I don't know if the health department does it, but was there any, site visits? Do people use the mask and the sanitizing, social distancing, all the requirements they must adhere to? Is those checks done? Because where was that found? And maybe just another question, Chair, is the vaccines. I know he spoke about the vaccines. All I want to know is, can private hospitals secure vaccines? That's apart from national, but can they independently source for vaccines? And also, when it comes to public and private hospitals, is it on affordability and vice versa? What if the public sector strained, and will they, as they did in the past, work hand in hand with the private hospitals in order to make sure that people are vaccinated? Thank you, Chairperson.
Thank you, Honourable Christians. The EFF and Freedom Front Plus are absent to the meeting, so I will then hand straight over to the Minister and HOD for responses to those questions. Thank you.
Chair, so that we don't waste time, I think Dr. Klute is going to answer most of them, but it is crucial to explain that, as we have already presented, that when it comes to when will be the 3rd wave, nobody knows. But what we know is that there could be a 3rd wave, because what we see in other countries, it is happening, where in other countries actually they've been on the 2nd wave, long 2nd wave, a period, whilst there are others, like in South Africa, where you'll find the differentiation. There's a gap between the 1st wave and now it's a 2nd wave, but we see there's a gap because their numbers have gone down, and then we don't know yet when will be the 3rd wave. But what will influence the 3rd wave? It's about different variants, because we already indicated in terms of the 501YV2 is highly transmissible. So if now people gather and we have got an existing variant that we know that it can be transmitted immediately from one person to another, it means that many people could be infected at the same time. Also, because of the mutation, viruses, there's an evolution where they keep on changing and changing. So there might be other variants, which there are but we don't know in terms of what are their transmissibility that could happen. So it's one of those things that gets influence. And then, of course, as Dr. Klute presented, that it already shows that among the healthcare workers, this vaccination program is happening. The mere fact that the numbers are not as increasing, because if you saw in the slide that actually they are even below 20. There are times where it's a 1, there's a 3. So it does show that, because it doesn't mean that people don't go to the hospitals or to the clinics where they could infect the healthcare workers, but the mere fact that their numbers of infection is low. So it does show that at least there is some level of protection there. My point, when people are not vaccinated, especially and specifically the older persons, as he presented, that it does show that many older people, they haven't been infected because there are no antibodies compared to the young ones. It means that if now these young ones, the bundles of joy, especially when they go back home, if they've been, let's say, in the university or they've been all night and whatever gathering, and then come to these older persons who has demonstrated that there are fewer who have been exposed. It means that we do know when you are old and also when you have got diabetes and other comorbidities, it means that you are likely to be infected. So that's what is going to influence the when on the where of the COVID. Of course, with the movement during the Easters, coming in, coming out. When I started with a preamble, I did indicate that it mirrors differently. So that we're saying that in the Northern Cape, we find that it hasn't plateaued yet, although the numbers are few. What are the chances of, for example, in terms of people coming from the Northern Cape going to whatever? Similarly, if now there are people coming in, whether from Europe, I'm talking about the international travel, where it has got its own variants, not only in our variant or from the UK, that will influence if they bring other types of the variant, or Brazil. So these are all things that will end up influencing all of those. So remember, Christians, when we're asking about the outbreaks and all of those related to the churches, remember, people might not necessarily that the outbreak might be actually found immediately from that specific gathering. But there might be people coming from the different areas where we say that the church, let's say, is in Belleville. And then there are people who will be coming from Stellenbosch. I'm talking now, it's Easters, others from the Khayelitsha, others from the northern suburbs and whatever, all of those. So when they go back home, to their homes, because they're where they might have, it might be the source of infection. So there might be at the time those 5 or 4 people in that house or in the area, there might be some of the outbreaks that are there, but at this stage might not necessarily link up to the church. I think he did a presentation about at the university in terms of the students and all of those. So what we're trying to highlight is that if you are alone, only 2 in your bubble, you get infected, it means there are only 2 of you. But if now we're gonna go and meet with the others, then that's when we find that there's a high level of the infection. It is true that we can't only blame the churches, because in the restaurants, that's where most people don't even wear masks. Once they spray hands, they sit and then they talk and then they drink. Masks are not even there. Whereas in the church, because I've attended about 3 churches already, whereas in the church, you'll find that almost the whole congregation where I've been, they are putting on their mask. It's fine that it might be the pastor who's there, who's preaching, whoever is there in the pulpit. But throughout, most of them put their mask. So I agree with you that it's unfair that you only mention one area, but we do know, especially the funerals where people, they hug a lot because they want to support each other. So it's one of the likelihood that where people could be infected. I think let me Dr. Klute for you, but lastly about the variants and all of those again. The variant that was found in South Africa with a team from the University of KZN, Professor Oliveira, and also others, even from the Oxford, because they are working as a team, as a researchers. That's a variant that they found in South Africa. The variant they found in the UK is a V1, but they are using different names. B, whatever, all of those. There is also another variant coming, also found in Brazil. It's not unusual to have a variant. That's what the virus does. It keeps on mutating itself. But what we are saying is that that variant that was found in South Africa, the 501YV2, now is already in more than 100 other countries. Similarly, with the variant that was found in the UK, is also everywhere. And definitely the Brazil variant, the New York variant, the whatever, it's found everywhere. So that's why we're saying that with the international traveling or even hosting people who are coming from the other countries, they might come with the different variants depending on the level of the vaccination of them. But remember, for us in South Africa, we are not vaccinated yet as a public. It's only 50% for the healthcare workers. That could also influence the when and the how of the third wave. Thank you. Over to you, Dr. Cruton.
Thank you, Minister. Chairperson, I will go quickly over then some of the areas the Minister didn't cover. Just to indicate to Member Philander that the doses that we've received and what I've put in the slides, we are confident that we will receive the allocated doses to allow us to complete phase 1 during the course of April. We are also confident that we will get the allocated doses to allow us to commence phase 2. And these allocations that's been done to date is done in consultation with us. We are very much part of all the meetings when these allocations are made. And you can understand, because it's for healthcare workers, the allocations are made on the total number of healthcare workers per province, both in the public sector and in the private sector, and in community settings through non-profit organizations in other sectors. So on the basis of that you will see the allocations that we got in our tranches, and if you add them all up, we've received 54,000 out of the initial 300,000. It's on that basis that's allocated to us. As far as the third wave projections, the Minister is correct. Nobody knows, but as I said, our infectious diseases specialists are part of the Ministerial Advisory Committee that's working with the National Modelling Consortium that did the projections previously. They are busy putting all of these factors together, and they will develop their first set of modeling scenarios over the coming weeks. When that happens, we will obviously be making it available, and we will then have a discussion about what it means for us in the Western Cape. The Minister has indicated the UK variant has been detected here. Our laboratory at Tygerberg said that they picked it up, but they picked it up once about 3 weeks ago. They haven't seen it out of the other samples. So it's unlikely that the UK variant has spread rapidly in our setting. Member Dugmore, just to indicate to you the slide that you are referring to is here. Chairperson, can you see the slide?
Yes, we can. Thank you.
Just to indicate that there's George. George has got 3,618 or 16 vaccinations done already to date. They've got another 9,760 coming up. In terms of unsolicited bids, the language we're using is that every person that says they got vaccines, that we didn't approach the suppliers. So we've only approached Pfizer and J&J. Everybody else that has indicated that has made contact with us as a department, that is the 28. So when we say unsolicited, it is the 28 unsolicited bids. And that is the ones that we have a clear supply chain process. We ask the person, please tell us which vaccine, where is it being produced? Do you have the clinical data? Is there an application at SAPRA? Does it work against our variant? Blah, 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 blah. And that's what we evaluate when we get the returns. So that is for all those 28 are regarded as unsolicited bids because we didn't go out to seek for it in terms of that. In terms of J&J, that is our first prize. J&J is a single dose, it's cheaper, and it is logistically much better to administer, so it is the first prize. It's currently going, how quickly can we get the supplies that we require for the country, and therefore Pfizer at this point in time is a supplementation of the ability to get J&J. But we definitely, if we had enough J&J vaccines to cover all our population in the quickest possible time, that's the one that we would have preferred for our setting. And from the outset, our scientists advised that that would be probably the most appropriate one for us to go for. In terms of rural areas, the rural areas that you just saw, we have George. From George, yesterday, the first vaccinations were done actually physically in Central Karoo. That's the furthest point from George, so that there will be a site in Central Karoo. Caledon has got a site in Overberg. When we start going to the expansion of what I call the second part of the healthcare workers, we will open up more sites. So each geographic area will have more sites. As I've explained, each team is planning for phase 2 to have multiple sites. So systematically going from 1 site to 3 to 5 to 10 to 12, that's going to be the plan in each geographic area. For what we've done now, we now have a footprint in each geographic area, and we will systematically expand it from there. The 1,132 employees that's been employed, they are contracts, they're employed on contracts. So it's not labor brokers, it is contract employees of the department. And that's the people that we currently employ in that way. And then just the last couple of questions about the holiday period in churches, the minister addressed that. We have got documented instances where funerals have been the seeding of clusters in multiple cases. We've also got where church services has been the seeding of clusters. Our teams get those cases and they can track where the source was and where people got together. The issue about compliance, the issue here is we have a faith-based leaders section that Minister Meyer pulls together. There's engagements. I spoke to that gathering of people across all the faiths. And many people have been very responsible in that regard, but there's a few people that's been irresponsible. But through that engagement, we make it incumbent on the people in the faith-based organization for leadership from the entities. A lot of them have asked for advice from the health department. A lot of people are putting the things in. But we are not sending out people to go check every single church to see whether they're compliant. It's about the responsibility to do this responsibly and looking after people so that there is no additional new clusters formed. And then private hospitals, public sector hospitals, everybody currently are getting their vaccines from the single national program as we speak. Anybody potentially could procure vaccines. You've seen our attempts to start procuring vaccines. We think by about September, we could potentially start procuring directly from suppliers in supplementing the national program. The private entities potentially could do the same, but all the private hospital groups have committed themselves to work within the government program. That brings me to your second question. Vaccinations is supposed to be equitably available for everyone that needs it. Affordability and whether you are rich or whether you are by means is not a criteria for getting a vaccine. Anybody that needs the vaccine should get it. Therefore, the program is about making sure that if we say over 60, we say it's everybody over 60. Whether you live in Franskraal or whether you live in Klipprand outside 200 kilometers outside of Matsikama, outside of Vredendal, or whether you live in Bishop's Court, you're going to have equal access if you're over the age of 60. That's the principle. And that's why we're saying nobody will get charged at the point of vaccine administration. That will be charged in the background if you have medical aid. If you don't have medical aid, it will be free of charge to you, but it's not a way of buying your advantage over somebody else. That's why the public sector and the private sector are working jointly to make sure that everybody get access to the vaccines. So thank you very much, Chairperson.
Thank you very much, Minister and Dr. Klütti. We have time for another round of questions. So again, I will start with the DA, Honourable Verlander. Do you have any further questions for the Department of Health?
Yes, yes, thank you, Chairperson.
Thank you. We'll do another 3-minute round if you need the time. Thanks.
Thank you, Chair. Chair, thank you, Dr. Klütti, through you, or rather through the Chair to you. I note in terms of those batches that we receive, one would think, Dr. Klute, that the more and the quicker you receive those vaccines, the sooner you can conclude phase 1. Why is it? Is it because of availability? Why is it that so little is received in each of the batches? And Chairperson, perhaps if I can also latch on to that, the President also made mention last night of the 11 million. There's still an agreement to be finalized for another 20 million J&J, as well as another 20 million of Pfizer vaccines as well, in ultimately to vaccine the 41 million South African population. Chairperson, my question is, according to the department, these various vaccines, and I know there was also made mention of UN vaccines ultimately, what is the department's take on the efficiency of those vaccines in South Africa, and the lines of options that the national government is considering for South Africa? Will that ultimately be efficient in order for us to reach population immunity? That is the one question. And then, Chairperson, I also missed in terms of, I understand the variants and the mutation thereof, but also I just missed is the UK variant, is it a more deadly one?
Thank you, Honourable Philander. I'll now see the ANC. Any questions from the ANC?
Yes, thank you, Chairperson. Chair, allow me to just say this. HOD, a very informative presentation. Thank you for that. And thanks for the explanation on the personnel issue. But what I want to know, why are there no posts for EMS personnel despite the challenges? And then, Chairperson, if you can go to slide 33, if I can get the indication of the breakdown of vaccination per health worker categories and facilities they work in the region. Then the last one, Chairperson, is on the issue. I want to understand why private and public are vaccinated at different sites in the metro, while we are in the rural area. There's a combination. Thank you so much, Chair.
Chair?
Yes, Honourable Dugmore, do you want to take the remaining 2 minutes?
Yeah, thank you very much. Thanks again for those responses. I'm really appreciative of Dr. Klute's explanation around equity in regard to access, that this is a right which people have. I think that one of the issues that begins to impact on that right potentially, and it's linked to the question that Member Van Voorgel raised. I mean, obviously in the first phase, I presume a health worker from Swellendam, would be transported, by Provincial Health, or if it's a private hospital, to Caledon. But I think we're going to face serious challenges when we get to the need to reach all of our elderly, and the issue of transport, I think, becomes a major issue in regard to where those sites are set up and how the elderly in particular will reach there. So what I wanted to ask, my understanding is that the funding we're getting as a province from national relates specifically to the vaccine itself. And could you just confirm that all other expenses related to storage, distribution, and so on are to be covered by the province? So I'm asking, in further phases that have been referred to, what is the thinking around actual transport for indigent members who literally, if they had to take a taxi from Swellendam to Caledon, and I presume obviously it's going to be better access, that becomes literally unaffordable for many people. So just a word on transport and the confirmation of the funding policy from national, what they are paying for and what the province is expected to pay for. Thanks.
Thank you very much. I'll now see the ACDP. Are there any questions from you, Honourable Christians?
Thank you, Chair. Yeah, and I want to concur with the other members of the questions being answered. Just a question, I've asked it a couple of times, but let's ask it again. The ivermectin, seeing that we don't know when we will have the third wave, and what is the department's stance on ivermectin? I know that us, the ACDP, and other institutions took SAPRA and the National Minister to court to have this used, because we hear of stories where people were cured when it came to having the disease. If the department, and I know that Stellenbosch and other universities were doing research, if we can just get an update on that of the ivermectin. And secondly, just a question, the street people, when it comes to that, and how are the department going to vaccinate the people, the homeless on the street? We know with the lockdown they were put in a camp, forced actually in a camp, and just do the department have a plan of action when it comes to the homeless and those people that don't have a fixed abode? Thank you, Chair.
Thank you very much, Honourable Christians. Are there any then other questions from members? Can I hand over to the responses? Okay.
Sorry, Chair, will you maybe just allow one more last round, or do you want us to ask them now?
Maybe let's just do another round. That's probably easier. We do have the time. So I'll hand back to the department for responses at this point then. Thank you.
Chair, if I could just make one response related to the phase 2. Again, remember, we are not even finalized with the phase 1, because the vaccines that we are receiving for healthcare workers, as we have indicated, it will cover only 50% on our side, which is the about 40 to 50, which is the 133,000 that we need to vaccinate. That could only be accommodated with a 500,000 that is for the whole country. So it means that there will still be more when we get now another batches or tranches, but not from the study group, because it will be completed by then. So my point is about where are we when it comes to the phase 2? Whilst the president indicated that by mid-May it is possible to have the vaccination for the phase 2, but again, it depends whether we'll be receiving those vaccines. So the question about whether how it's going to be with the transportation, I think probably the slide. I don't know that slide. But if you look in terms of how it has been, they've worked it out in regards to the vaccination day and vaccination sites, where they've grouped them according to small sites, where they look, for example, in the small sites where they can vaccinate about 90 per day, with the 1,200 small sites, which will yield to about 110,000 vaccinations per day. And then medium size and also the mass vaccination sites where we could use like city ICCs, the stadia, the gyms, the hotels, and all of those. The medium sites, we talk about the existing hospitals, the medical centers, the retail stores, and then the small sites, it could be the clinics, GPs, pharmacists, and all of those. So the question about how will the people be transported, it might be probably when now possible. There's a slide there where they already know how many people over 60 in certain areas. So it might be where you find that if there are 30 or 40, 50 people that needs to be vaccinated in an old age home or in a particular area in that street, there might be a mobile that could come and vaccinate them. Similar in regard to if there are people who are working all in that mall, it could be probably you can use the clinics and whatever in that mall where people could be vaccinated. So the similar principle applies, that you don't walk more than 2 kilometers in order to access healthcare services. I bet you, when it comes to the vaccinations, it means that because the target is about, at least for us, within 3 months, that phase 2 is supposed to have completed. That's why when we work it out, while South Africa says that they could do 250,000 per day or to 300, and then for us, we're saying if we could do 30 to 36,000 per day, because already we have sharpened our acts. For example, now where we could vaccinate 2,500 per day, although initially we used to have a target when we started of about 1,000. So the question about why the other is there's a private hospital in the metro and then the other, remember, it's part of the implementation study. And what they do, there must be an access to the researchers, because it is them who draw up the research pharmacists who draw up the syringe, because they say 2 doses, and it must be labeled accordingly, and all of those was part of the research site. So in the metro, we started initially with a tiger bag for the Eastern Metro, and then GSH for the Western Metro, inclusive of the private. And then with the arrangements, it was about the private, they are available over the weekends. But not only us vaccinating them, but also even for them participating. Because the first time we were the GSH, we even ran out of the vaccines, not because it wasn't planned, it's because when people register and then they get in confirmation that where you should go and vaccinate, but others ended up coming late. And yet for them, for the vaccinators, researchers, they will have drawn so many of those, which each and every time that they've taken, it must be used within two hours. So up to where it became quite heavy for both in terms of the weekends. But remember, each and every site gets accredited. So whilst the provinces work it out, it's supposed to be credited not by only by the national, but also by the by the research team in regard to the access to the registers. So Melomed is the only one that volunteered that, okay, we will reduce the workload. They applied to the national, and then they were accredited to be a vaccination site for the whole of the private, for all other groups, even the private nurses, for private speech therapists, and everyone go, even for the NGOs, they go there. So for them, it was like that. When I went to Worcester, where, remember, Worcester also takes up for Overberg, for example, for the Overberg. When I went there, and then there were also the private, and then I asked, how come that the private around the corner, they cannot be, because they're also part of their assisting as vaccinators, because for them, as a private hospital, I mean, there is no carrot to do that. So therefore, they'll rather work with us and bring their staff, and then also in turns where they'll say today is going to be the net care, tomorrow is going to be the ER, and they also so forth. So you find that when you go to these sites in terms of the cubicles, it will be a cubicle that's, even if you go to Melomed there at the hall that they are using, you find that cubicle for MediClinic, cubicle for whatever, and then they could be able to make use, because remember the allocation is also from national, where it says 1/3 private, 2/3 public. So when they give us the doses, already there is that allocation. So sometimes if it's finished for the private during that week, you won't be able to get it if it was about you qualify so many doses. In the public, in the rural areas, as I've just explained, that with the Worcester, it is them who indicated that they don't have the capacity in order to be able to vaccinate for all. So therefore, they'll rather work hand in hand with the public. Similar also in PAL, and also similar, which is, for example, in PAL, actually they were saying that, can you please take over, at least you are at more advantage, whether you do it in Stellenbosch, because they've got many of the private. Noting with the private, they don't appoint, their doctors are not employees. It's the nurses and other categories are the employees of the hospitals, but the doctors, specifically the specialists, they've got their own practice, but now referring patients, they've got patients in this private. So when you say now that these vaccinators, they must absorb the whole work of other private, becomes difficult. So that's why we congratulate the Melomed for even taking up similar, which is I was hoping for George they'll be able to do, but Having said that, you will find that they're doing quite a lot of work, because as Dr. Kute has indicated, it's not only for the staff that coming from in that area. The George, they do the whole of the Central Karoo, plus also all other parts of the GRD where people have been traveling everywhere. Like yesterday, the numbers, there was 173 private, there was 156 public. In total is 329, noting that the NGOs, they also form part, they're called private because they are not PESAL, they're not part of us. So you need to understand that in terms of where there will be, as I indicated, everyone will be vaccinated when there are the vaccines available. And also in terms of the plan, it is possible to have as many sites as indicated where you could be able to vaccinate all of these people. But the nitty-gritty in terms of whether are you going to go to be vaccinated in an old age home, or are you going to go to vaccinated in a hospital, or there'll be going to be a mobile, it will also be influenced what type of a candidate of the vaccination that you get. Making an example, we may not be able probably to vaccinate using Pfizer, let's say in Matsikama, for example, but we might be able to use it more in the Cape Winelands or in the metro because of the in terms of the cold chain and the availability of the certain type of syringes. Thank you, Dr. Klute. Are you going to speak about the EMS?
Yeah, no, thanks. Thank you very much, Minister and Chairperson. So just to explain, I think the Minister explained, but just to explain for Member Philander, the Sisonke is a research project. We have not used any procured vaccines yet in South Africa. So I think people get the confusion that actually we've started the rollout program. So if you regard the rollout program as a program that is with your own procured vaccine in the absence of research, we have not started that yet. Sisonke is a research program. We've not paid for the Johnson & Johnson vaccines. It is the leftover stock of research vaccines that was gathered from across the world, and it came in batches. It came in 80,000, 80,000, 80,000. There's another 200,000 that's coming now. It's coming in batches. That's why when we get an allocation as a tranche, it is our subdivision of the arrived vaccines. That's the way it is. It came in those ways because it comes from across the world. It gets jetted in here and it gets used as part of the research. So as Minister is saying, by the middle of April, that additional 200,000 doses will be allocated and it's finished, and Sisonke is finished by the middle of April. When we've got that, each one of that there's a researcher, they must pull it up. Therefore, the sites are limited. Therefore, she explained how in the private sector that actually wanted to do all of this, and there's research available that Malamet stepped forward. In the rural areas, there's not sufficient capacity to duplicate between private and public. And therefore, there was an option for the private hospital or the private public hospital to come forward, and they're doing it as a joint venture. As he describes how it's happening in George, that's the way, in Worcester, it's happening in George, it's happening in Paul. And from there, we are adding additional sites. When the first Pfizer vaccines comes that we procure as a country, it comes into our system like we would have rolled out when Covishield was put on hold. That kicks in. So for the first time when we have procured vaccines, does our vaccine rollout program kick in. That vaccine rollout program has got many more sites. And I think just to come to Member Dugmore's question, it will mean there will be a site in Beaufort West. There will be a site in Swellendam. There might be 2 sites in Swellendam. The issue is also there's going to be mobiles. But even above all of that, Member Dugmore, we spoke to Transport and Public Works yesterday. And even with them, we are possibly looking at a backup system where we could be transporting people using the red dot or the blue dot light type system, where we can get people to a site and back. So we're doing all of those to make sure that whatever impediment is there, that we guarantee the equity of access that's required for the vaccines. When it comes to the UK variant, there has been some evidence that the UK variant is not only more transmissible, but it is also causes more severe disease. There's no evidence that the variant 501V2, which is origin in South Africa, causes more severe illness. But the 501 V1, which originated in the UK, there is evidence that it's causing more severe disease. Both are more transmissible than the previous variants. I think, Member Philander, I didn't quite understand the issue about efficiencies. The issue is there's a supply line. There is Pfizer vaccines coming. There is a system in place that once it gets here, BioVac will take the vaccines, will deliver to this province. We have a system, we distribute it. As I said, when the new procured vaccine comes, that's the first time that we're going to go to mass vaccination and scale to the sites in terms of logistics, and that's what we're planning for. In terms of the posts, the 1,132 posts, obviously, if the committee asks, the department can provide the breakdown of those numbers into categories. And just to make sure that for the question that's asked, EMS posts generally, the budget for those posts has been under pressure for a long period of time. This money that we're getting now is COVID money that, in a sense, we get as part of year one. Then we must plan for year two, then we plan for year two. Our budget that was signed off last week has a reduction in budget in year three. So that's why we have people on contract positions. And obviously, we're looking at critical posts across all the categories, EMS being one. And we're looking at competing needs all the time. It is not that we don't have, and the point is the budget is under pressure, and the budget, because of COVID, is more under pressure. So there is not a surplus of budget. The whole healthcare system in the country is suffering from a shortage of budget, but the whole of government resources has started as a shortage for every sector in this country. So we're going to have to really deal with this issue that we're dealing with COVID and vaccination, but the healthcare system remains under pressure for all posts in terms of what we want to, the services we want to render. Then in terms of ivermectin, Member Christians, our position is very clear. There's a national advisory committee that has looked at all the evidence. And that committee has examined all the evidence, and they look at all the evidence all the time. There is not sufficient evidence to suggest that ivermectin is effective in the management of COVID. It's not in this country, it is not globally. We're not the only country where that expert committee has made that ruling. That's why our position in this province is we are in support of ivermectin being part of clinical trials, because if the evidence is there, we will implement it immediately, but there's not sufficient evidence to do so. In terms of street people is one category of vulnerable people. I think Member Dagmar also spoke about vulnerable people. So if we really want to be equitable, we need to put the focus on how do we get to vulnerable groups. So part of what we will do in the steering committee is to say in each geographic area, what is the planning for vulnerable groups? And street committees definitely, street people will be part of vulnerable groups. Another big group of vulnerable people are people that are refugees, that are not registered South Africans. We need to understand, because one of the requirements we have for the system is you need to be registered onto the system. Now, to be registered onto the system, you require a South African identity number. So we're going to have to figure out in the identity number and the registration of the system, how do we get A, street people onto that system, B, people that do not have ID numbers. So that is a challenge, and we're going to have to deal with that in the planning. Thank you very much, Chairperson.
Thank you very much. Thank you very much, Dr. Kleti and Minister Mbombo. We're now going to do a very short final round. So we've got 10 minutes before SAPRA joins us. Can I just see then for 1 minute, are there any final questions from the DA?
Not from my side, Chairperson.
Okay, thank you, Honourable Philander. Honourable Dugmore?
Not from my side, Chair.
All right. Okay, and then Honourable Christians, any final questions from you? I might have left the meeting. All right. Okay. Well, that then concludes the round of questions to the Department of Health in the Western Cape. I'd like to thank Minister Mbombo, Dr. Kluti, and Dr. Balabji for joining us today. As usual, we're very grateful for all the information that you provide us with, and as well as the weekly reports that you send to us without fail. We wish you well in the coming days, and we look forward to engaging with you again in the future.
Thank you, Chairperson.
All right. Thank you, Minister. You're welcome to join us for the remainder of the meeting. However, I know you're very busy people, so if you'd like to exit the meeting, you're most welcome to. We do have 10 minutes, so I'm going to ask the procedural officers if they could perhaps beam up the minutes that we need to adopt, and then we'll take a quick break before we proceed with the second part of the meeting. Thank you very much, Ms. Hassan-Musa. We've got the minutes of the ad hoc meeting on the 4th of March. Please check attendance. Right, any edits or amendments to page 1? None. Then moving down to page 2. Those that were present, welcome. Any edits or amendments to page 2? If there are none, let's move on to page 3. And resolutions. Then just under 4.4, Honourable Van Vogel, can you just check that we've captured that resolution which came from you correctly? Honourable Van Vogel, are you still on the line? Okay. All right, are there any edits or amendments then to page 3? If there are none, could I have a proposer and a seconder? Thank you very much, Honourable van der Westhuizen and Honourable Mitchell. The minutes are then duly adopted. We're now going to have a short break, and we will then reconvene with SAPRA joining the meeting. So we will just suspend the meeting until 15:45. Thank you very much, members. of SAPRA has just informed us that she is running late and will join our meeting at 4 p.m. So we will remain suspended until 4 p.m. Thank you. According to my watch, it's 4 o'clock. We will now resume this ad hoc committee meeting dealing with COVID-19. I'd like to welcome Dr. Semete Makokotlela, who is the Chief Executive Officer of SAPRA, and her team. A very warm welcome to this Western Cape Provincial Parliament ad hoc committee on COVID-19. Thank you very much for joining us today. We are very keen to learn more about vaccine approvals, and in particular for the COVID-19 vaccines. So with that, I'm going to hand over to you directly. If I could please ask that the presentation be approximately 15 minutes so that we have some time for an engagement and a Q&A afterwards. Doctor, thank you very much. I'll hand directly over to you. Lovely to meet you.
Thank you. Thank you so much, and thank you for having me. Apologies again. I was just speaking at another event that took longer. So I'm going to share my screen. It seems you are able to see it.
Yes, we are. Thank you.
Okay, great. Thank you. So I'll just give a high-level update on, COVID-19 vaccines. But before I do so, I thought, let me just speak about who we are, what we do. So as the South African Health Products Regulatory Authority, we have a responsibility to oversee all health products that are within our mandate. So that is health products for human and animal use, so specifically medicines, as well as medical devices. That includes, medical devices, in vitro diagnostic tests, as well as medical devices that have radiation sources. So our mandate is quite broad. This also includes oversight for clinical trials. So we don't actually conduct the clinical trials. However, we authorize and we oversee the implementation of clinical trials. And lastly, it would also be complementary medicine. So our mandate is quite broad. And what we do is that we monitor these products, we evaluate them when we receive applications for registration, we investigate once these products are authorized into the market, we do ad hoc inspections of those products, and also we inspect the facilities where these products are manufactured or the facilities where they're distributed, and we also inspect wholesaling facilities in terms of compliance to good practices. So our regulatory decisions are then in the area of medicines, and vaccines would fall under that. We would make regulatory decisions over the conduct of clinical trials. And then also what we have is a Section 21 mechanism, which is a mechanism for any unregistered products. So when it comes to COVID-19 specifically, I mean, one of the things that we encouraged all the manufacturers to do is to have pre-submission meetings with us. So this is a meeting, where we would take them through what the application requirements are, particularly, considering that, these vaccines, are newly developed. A lot of the manufacturers were uncertain around the regulatory requirements, etc. So we had these meetings with them. We also, when we're engaging with them, we're able to establish how much information they have, whether it's adequate or not, and also guide them on what is required to support the application. We would take them through the various types of reviews that we have and the types of registration options that they have, and also reflected on the reliance pathways that we could apply with other regulators across the world. So just very quickly, I mean, we met with a number of companies over a number of days. J&J, AstraZeneca, they've got a number of manufacturers, as some of you may be aware. So one of them being our pharma and the Serum Institute. We also met with Pfizer at the time, with the Russians around the Sputnik vaccines, and the Chinese Sinovac, and also we met them regarding Sinopharm. So pretty much all the, vaccines that have advanced quite significantly, we've met with a number of the applicants or the pharmaceutical companies. Whether they've applied or not, I will share with you just now. There's different mechanisms that we use to authorize these vaccines. The first mechanism is what we call a rolling review of submissions. And this is a practice that a number of us, regulators across the world, under also the guidance of the WHO, we agreed that we would take this approach wherein instead of waiting for all the data to be made available at a certain point, we then encourage the manufacturers, or we indicated to them that they can submit the data as it becomes available. We would review and then, have ongoing discussions on the quality and any queries that we would have from that data. So it is again one of the mechanisms that has enabled us to move a lot faster with some of the applications than we typically would, because we didn't wait to get the full data package at a certain point. We also applied the mechanism of reliance. This is where we work with other regulators, where we take into account and give some weight to the assessments that they've conducted, and we then would utilize that to enable us to reach a decision. So that decision, we remain to be to have our autonomy. We remain to be able to make a different decision to what they would have, but at least it enables us in that we can apply some level of reliance on the work and the assessment that they've done. We would also typically get a sense of what questions they ask the applicants and what the responses are. Reliance is also applied in instances, where, the national control labs, who are all under the, WHO accredited labs can then rely on the other lab wherein they share reports, etc. And these are the labs that would do the quality control when the product enters the country. I'm sure many of you saw with the AstraZeneca vaccine that when it arrived, it had to go through the quality control assessment. We're also part of, the WHO joint reviews. They call it a collaborative review program, where we've got 5 South African evaluators, being SAPRA staff and other expert evaluators that are part of this global collaborative review mechanism. So we really, as a country, are contributing to even decision-making by organizations such as the WHO. The other mechanism we have is a Section 21, as I've indicated, and this is equivalent to what you may have heard other countries where they refer to it as emergency use authorization. And so, this is where it's a mechanism that is in place as per our Act for access to unregistered medicines. It's not only medicines, medical devices, and IVDs, wherein we're able to authorize an applicant to bring in a specified quantity of a product for a specific period under specific conditions that we would put in place. Again, this is a mechanism that is extensively utilized, now during this pandemic, but also in other instances, where there's an urgent requirement for a certain health products. And we've got regulations that guide us how we do that. For COVID-19, we considered this and we put in place a framework and guidance that we've published, and industry is then utilizing that so that they can comply and apply through this mechanism. So in essence, we've got a number of applications that are in our pipeline. So remember I said there's different types of applications. So this slide, I'm reflecting on those who have applied for market authorization. So this is not the Section 21. This is where, they would get market authorization. We've got J&J, we've got Pfizer, we've got Sputnik, as well as Sinovac, that are all currently under review. And again, this is for market authorization. We then have applicants for the Section 21. So this is for the emergency use. The market authorization, the reviews typically take longer because there's a lot more that you require in those instances than you would do with a Section 21. So you're aware of the authorization that we gave for the AstraZeneca vaccine. And we were again hit with the caveat, and this new variant really threw a curveball to us, wherein we had authorized it on the 22nd of January based on the data they provided to us against the wild type strain. And then we got the results then from, the 501YV2 variant. And you all are aware then of the decision that the country took on that. We're still reviewing the detailed report that they provided to us on the performance of this vaccine against the variant. We also authorized a few weeks back the Pfizer vaccine under Section 21. So they've also applied for full market authorization in parallel. And we're currently reviewing the Sputnik and the Sinovac vaccine. In addition to the actual vaccine registrations that we have, I'm not going to discuss these slides in detail, but just to highlight, that South Africa has participated in a number of the vaccine clinical trial studies, a number of them being global studies. So I think the country, we must really commend the country in terms of, our scientific community. And I think it speaks to the caliber of our scientists. It speaks to the caliber of our infrastructure when it comes to conducting these studies. And a number of them are phase 2 or phase 3 clinical trials. The first one actually that we had approved was the AstraZeneca, the Chaddock vaccine. And the reason again why, they didn't have the data against the variant, we authorized this quite early on, sometime last year. So by the time that they conducted the clinical trial, there was no data. And when you look at when we started to see an increase in this variant, they were close to finalizing their studies. So they conducted the clinical trial while it was still the wild type that was prevalent. We also had there's a vaccine, the Novavax study that was also going on under the leadership of Prof. Mahdi. We had the Pfizer vaccine that was also evaluated in the country. Pfizer actually all the way from phase 1 to phase 3. We've got also the J&J vaccine that was also trialed in South Africa, as well as the, sorry, this is the second one of that same one. So this is the Janssen for the prevention. And so I think that's just a duplication. I apologize for that one. The other one that we had, this is now the Sisonke trial that I'm sure many of you or all of you are aware of. We also had to authorize that trial. It is different to all the others because it's a 3B, which means it's an open label, single arm phase 3B. And, we've authorized phase 3B studies historically as SAPRA. I think there was a time when we authorized it for the Depeverin ring at the time, a few years back. So this is definitely, studies that we've authorized in the past, and this then happens to be one of them. We also had the BCG vaccine. This is also one of the earlier studies that we had approved, and we continuously get data on these studies. There's also the MMR vaccine study that is conducted. It's currently at phase 3. This is where they're evaluating the measles, mumps, and rubella virus vaccine. It's a live vaccine. They are evaluating it, for efficacy in the prevention of COVID-19 symptoms. The next one is an adenoviral platform, again, which is sponsored by Immunity Bio. This was again covered in the media a few weeks back, if not last week. And the study has also recently been authorized. And we've got another one wherein they're using a fusion protein, and the sponsor there is Clover Biopharmaceuticals. So, as a country, we currently are involved in just about 10 clinical trial studies, and it's the most in the continent. As I said, this is really commendable indeed. We have a few others that have recently been submitted and are currently under evaluation. And we're actually quite happy with the 2 that we got, because we've been getting a lot of questions around the safety and the efficacy of these vaccines in pregnant women and in children. So it's good to see that there are then studies that are in the pipeline, but all of these are still under review, so there hasn't been a decision against these. And I'll pause here. Thank you, just to enable time for questions.
Thank you very much, Dr. Semete, for that presentation, and very, very interesting for us. So thank you again for joining us this afternoon. I'm sure there are some questions from the members. We are a multi-party committee of the provincial legislature, with members represented here. I'm just going to go by show of hands for questions. I know I certainly have some. Can I just get an indication from other members who would like to pose questions? Right, while we're waiting for members to then do that, if I may, would you prefer a list of questions to respond to, or do you prefer to do one at a time?
I think we can take about 3 or so.
Okay.
I guess, yeah, to be efficient.
Okay, perfect. All right, so my first question then is, there's various vaccines in different statuses or phases of approval. Do we currently have a vaccine for COVID-19 that is approved for rollout to the general population? That is not part of a trial, but for rollout to the general population. So that's my first question then. And then my second is and it's related, is the president announced last night that phase 2 of the rollout, which would be amongst the general population above the age of 60, is scheduled to begin in around May or middle of May. How does the limited approval of the Pfizer and J&J vaccines, does that have any impact on South Africa's ability to then move into that phase 2 to vaccinate the general population in those age groups? Then my third question then is regarding ivermectin, which is obviously very topical. There's been a lot of talk about it. Could you tell us a little bit more about the evaluation of it in treating COVID-19? Thank you. Should I take questions from other members, or should we stop there for now?
Let me take these three. Thank you.
Okay, perfect.
So in terms of the those that are authorized for the rollout, so definitely the Pfizer one that has the Section 21 authorization is available for the rollout if the country does procure it. So that one is available. The other one that we're quite advanced in terms of the review is the J&J application. So we hope that in the next few days or week at the most, we will be able to communicate, a decision. It's at a very advanced stage of evaluation, and that would then also be available. So any other, that is not under a clinical study would then be available for the government to access that. In terms of how it, impacts the move to phase 2. So basically, the authorizations that we give, so even though it's Section 21 being emergency use, this means that, they can be procured to be able to implement in the different phases. If the quantities that we've authorized are insufficient, the applicant can come back to us and ask for the quantities to be increased. And, it's something we've done in the past. And again, we've indicated to them that we're able to do that. And so, these vaccines, once they have authorization for us, they can really be used in the rollout stage. In terms of ivermectin, typically, with any new product that will be developed, you would still need to do clinical trials, generate sufficient data, and make sure that your clinical trials are properly designed so that you look at the correct endpoints. So the endpoints become very important. Your dose ranging, findings becomes quite important, and then safety analysis. And the key issue with ivermectin is that all the studies that have been conducted for now, we are waiting more data. There was an indication that we should get more around April across the world. Is that, the endpoints of the different studies are all very different. So you can't reach a very specific conclusion. The other point is that the studies were very small. There's studies with 40 people, etc. And those numbers are way too small. And then lastly, there aren't any studies that have done a dose finding. So again, it becomes difficult for us to say, to provide guidance in terms of which doses would be utilized and are those doses safe. And so hence in our compassionate access program, we've said the responsibility lies with the medical practitioner to say what dose they will use, and they then need to monitor the patient, and they must then give us feedback, because at this point, we don't have sufficient scientific data. So our positions remains to be that there's insufficient data to say ivermectin is effective for the management of COVID, but also we can't say there's sufficient data to say it's not effective. There's all of these studies that are ongoing. So there is that clinical equipoise, and hence we made then the program available. And that remains to be our position. And, a number of you may be aware of all the legal, matters that we're dealing with, and I can't talk around those because they're still in progress, but our position remains to be that on ivermectin. Thank you.
Thank you very much, Doctor. I'll now see Honourable Dugmore.
Thanks once again. Myself and Member Vin Vogel will share the 3 minutes. Thank you very much for the presentation. I think it's been very helpful. I would just like to get a sense of the timeframes in regard in terms of by when the committee would have been able to process. I think you referred to the Sinovac one and also the Sputnik one. What are the sort of timeframes you've indicated around the J&J that you hope to be in a position to announce a decision in a week? So in regard to those other two in particular, I just wanted to get a sense of the timeframes in that regard. And then secondly, obviously the public attention on the organization now relates to issues around the COVID vaccines. but has this process impacted on the other aspects of your work? And are you able to manage those applications, and have you actually requested additional staff and personnel to help you with what has obviously been a particularly busy process that you've had to deal with, these particular processes, monitoring research trials and going through your normal approvals and so on. So I just wanted to see whether the current staff complement of the organization is adequate to deal with the tasks that you've been confronting, plus the normal course of work that you'd be dealing with. But thanks very much. It's reassuring and comforting to get this report and to hear of the progress being made. Thanks.
Doctor, can we take a few more questions, or should we stop there? Okay, let's take a few more questions. Honourable Windvogel, over to you.
Thank you so much, Chair. Thanks, Doc, for the presentation. What I want to understand, under which circumstances can provinces procure only vaccine, and then what process is followed to procure a vaccine? What I want to know, does government wait until the vaccine is approved by SAPRA? And then lastly, Chairperson, if Doc can explain to me what is the update of all reviews that are currently underway as of end of March. Thank you, Chairperson.
Thank you, Doctor. I think we'll pause there to allow you an opportunity to respond. Thank you.
Yeah, let me start with the last set. So, I mean, in terms of this update on the reviews, that's what the presentation covered. So what I spoke to is the details as at today. We don't get involved in the procurement, so I would say that question can be posed to the Department of Health. Our role is to ensure that the products are registered, and when they're then available, we then monitor them for. In this case, we will be doing safety monitoring of the vaccines and any other post-market surveillance. So we don't get involved at all in any decision pertaining to procurement. In terms of the Sinovac and the Sputnik, I mean, these were received, Sinovac received now in March, sorry, Sputnik in March, Sinovac late February. So these are still at a very early stage compared to, J&J. I mean, J&J, it was a rolling review. They submitted last year already. So you can kind of get a sense of, how long, that will take. But what we found is that it depends on the quality of the information. There are instances, where there's a lot of back and forth with the applicant. So unfortunately, at this point, I can't say it will take us a month or 2 months to get Sinovac registered. It really depends on the quality of their data. And we've already, started with the review and, we'll be engaging with them. But it depends also on how quickly they come back to us on the queries that we would have. So unfortunately, I can't give you a specific time frame around that. I do apologize. In terms of, our capacity to deal with our business as usual, I mean, we and I think that's a challenge of being a regulator, right? That while we deal with COVID, the other areas, there continues to be needs. We can't put a hold, a pause on that. So we are very stretched. My team and I have not had a break since COVID started. We were, you may have seen on one slide, I remember we had a pre-submission meeting with AstraZeneca at this time on the 31st of December. So we really have been working through. So we're able to do what we do. So because we've had to just have all hands on deck, roll up our sleeves and work overtime. But this is not ideal and this is not optimal. So in our optimal structure, I mean, as a regulator, this total staff complement is about 450 or so individuals. We're currently sitting with a staff complement of about 280. So we're not adequately staffed at all, and so, we're putting in place efforts to recruit, but also to raise funding, from National Treasury for us to be able to fully capacitate the organization. We're very small in size considering the amount of applications that we have, but we've had to prioritize COVID. In some instances, I think it did cause delays in other areas, specifically, which is the session I was in now with the Clinical Trials Association, in that because we prioritize so much on COVID clinical trials, I mean, the 10 that you saw is vaccines. We've got a lot more on therapies. And so it has, in some instances, shifted a lot of our resources to focus on COVID and affected the timelines. But, whenever there's a quieter period when it comes to COVID, which is not a lot of times, we then try to catch up. So very tough times for us. Thanks for that.
Thank you very much, Dr. Semete. Can I check, are there any further questions from the members? If you could raise your hands.
Not from me, Chair. Thank you.
Okay, we have a question from Honourable Philander.
Thank you very much, Chairperson, and thank you so much, Dr. Semete, for being with us today amidst your very hectic schedule. My question would just be on if you can give us perhaps an overview on the efficacy of the submissions at current of the vaccines, please. Thanks, Chair.
Are there any other questions from the members? Doesn't seem so. Doctor, so it's short and sweet then. I'll hand over to you for those final responses.
Sure, thank you. So I'll speak to, I won't give away too much detail on this. I'll share what's in the public because also we are bound by confidentiality with these applicants. But, a number of you may have seen that, and I'll speak to the efficacy against the variant, which I think is the question that you're asking around the variant that's dominant in South Africa. The J&J vaccine had an efficacy of close to about 59%. The WHO threshold was around 50%, so we're quite happy with that. If you remember, the AstraZeneca, the efficacy reduced to about 20%, and that's why we could not proceed with that. The other one that has an efficacy above 50 is the Novavax vaccine. We haven't received an application for that as yet, and these efficacies are, with clinical data. There are a number of some of these vaccines that don't have the clinical data yet, understandably, considering the time that, the studies were done. They've got lab-based data, and what we will be doing is that we will ensure that these are monitored. So, for example, with the Pfizer vaccine that we've authorized, they will be submitting a protocol of how they will monitor the performance, considering the efficacy that they had against the wild type. And when we looked at their lab-based data, we were still quite confident to proceed with the authorization. I must say also that one thing that we've had to deliberate on is, with all this uncertainty and in some instances unknowns, right, around the disease, around the variants, we had to say as a regulator, what is the minimum required information we want to enable access? Because we fully understand that not all the vaccines will have the data against, this variant. So we needed to, be agile and flexible in terms of the, what we expect from them. So while they would meet the regulatory requirements, there are aspects that they will have to do as they proceed with the rollout. There's just some of these, none of us have the answers to that. And so we continue to assess with time. Thank you.
Thank you, Doctor. If I may, one final question. The COVID variant first found in Kent or the UK has now appeared in South Africa. And, the different vaccines may show different efficacies against the different types of variants, which makes this all very complex in how it's managed, how it's approved and so on. Could you give us some insight in how, if this UK variant first found in the UK then becomes the dominant variant here, would that then require a new set of approvals, or how would that work? Sorry, you're on mute.
This is the discussion that we're all dealing with as regulators to say, you know, what are we going to do when you've authorized a vaccine and then there's a new variant that emerges? We actually had a meeting of all the various regulators on Monday to align on those protocols. So very soon we will be, you know, publishing guidelines in terms of what we will do. So we've started with our guideline. So as you say, I mean, it's very complex. We don't know what we're going to get. You know, there's an expectation that we'll be, you know, experiencing a third wave. We don't know which variant, if there will even be, you know, a different variant by that time. So we do have to be flexible, update our guidelines as required, but also then build in mechanisms to say, how do we then collect more data? Because in all these instances, we do need the data to be available to enable us to, you know, make the required decisions. So yeah, that's an ongoing discussion. Thank you.
Thank you very much, Dr. Semete. I think that then concludes our engagement today. Thank you again so much for your time. And on behalf of the committee, wish you and SAPRA very well in these difficult deliberations and all of the hard work that needs to be done. So thank you very much for joining the ad hoc committee this afternoon.
No, thank you so much for having me. I really appreciate it. Have a good day, everyone.
You too.
Thank
members,
you. Thanks very much.
We'll proceed to our committee admin as the final portion of our meeting today. Let me just open my document quickly. Okay, so we can either look at adopting resolutions now or recommendations. Otherwise, members are welcome to submit them by 12 o'clock on Monday, or let's rather make it Tuesday, Monday being a holiday, Tuesday at 12 noon. That's Tuesday, the 6th of April. Can I just see, are there any recommendations or resolutions that anybody would like to table at the moment? Okay, if there are none, then please use the email opportunity. Honourable van der Westhuizen.
Sorry, Chair, you're a bit quick for me. Chair, I think for us in the Western Cape, it's quite important to learn whether some of the lockdown regulations are really effective in achieving what they are set out to achieve. And the problem that we've had up to now with many of the other changes in regulations were that they were a combination of regulations. For example, the ban on the sale of liquor was always linked to also, for example, curfews, etc. And this time around, obviously, there is a limitation on the sale of liquor, but the curfew or the lockdown level stays the same. And I'm just thinking that going forward, perhaps it would be very interesting for us to learn how effective this ban is, because now for the first time, I think it can be isolated as a single variable in the regulations. And obviously you will know that, you know, me being the chair of the Standing Committee on Agriculture, that and with the liquor industry being in trouble in many respects, that this is quite an important variable or important aspect for us from an economic recovery point of view as well.
Thank you, Honourable van der Westhuizen. So, I mean, if we were to put that into a recommendation.
Yes, thank you, Chair. If we could get a feedback after this weekend on whether this regulation, specifically the one on the ban of liquor sales over the Easter weekend, whether we've got historical data compared then with this year's data, and whether the Department of Health would be able to tell us whether it did indeed open up more beds in our hospitals, whether as compared to previous years, and whether perhaps, you know, they could relate that back to infection instances.
Thank you, Honourable van der Westhuizen. Could we perhaps proceed in this way? That's exactly what you've mentioned here. I'll include in my next letter to the Health Department on their next briefing to this committee, but we'll ask specifically for that information. Would that be in order?
Absolutely. Thank you, Chair.
Okay,
Thank you, Chair. Chair, would you mind if it went back to the year before the lockdown started, like say stats over the Easter weekend and Christmas and the Christmas holiday, you know, both sort of a pre-COVID and then obviously last Easter, I presume we were in level 5. We're now in level 1. So I wonder if they could just, you know, include a historical plus an overview of those weekends or holiday periods during COVID as well. Thanks.
Yeah, I think that's a good idea. We can ask for the last 3 years so that we have an indication in normal times and then the different levels. That would give us a good idea. Okay, so we'll then include that in the request to the Health Department for their next briefing to this committee. Thank you very much, members. If there is nothing further then, thank you very much for your contributions to this meeting. We will now thank the procedural officers for all the organisation of this meeting and adjourn. Take care, everybody.
Thank you, Chair.
Thank you.